So for the patient with upper cross syndrome, we're going to tend to be dealing with overactivity in the suboccipitals, upper trapezius, levator scap, scalenes, sternocleidomastoid, and pectoralis. So those are the tissues that I'm going to run through today, just talking about some of the ways that I do soft tissue mobilization on them. There are a lot of different techniques out there and lots of different ways that you can approach this, but here's an example of a way that you can approach working on soft tissue that I've found to be very effective. So what I want to do is first, whenever I'm doing soft tissue, I ask the patient to hold good posture. I want them up nice and straight, chin tucked, because I'm inspiring motion into their body. I want them to be able to get the proprioceptive benefits of going through those movements as correctly as possible. I also tend to start with passive motion, but as the patient learns what the movements are like and as their mobility improves, I'm going to ask them to take on some of the motions actively so that they can get a better feel for it and also start to retrain the muscles to activate the way that they were designed to. So the first one I'm going to start with is going to be the suboccipitals, and getting into the splenius, I'm going to go ahead and cradle the head so that the patient can just relax and let me have the weight of their head. This allows me to move them passively. You may need to just kind of cradle them into your elbow, whatever works best for you. And then from there, you're just going to go ahead and strip down through the suboccipitals and the posterior cervicals as you bring the head down into flexion. From there, I'm going to work into the upper trapezius. I'm going to take the blade of my forearm, and as I laterally flex the head away, I'm going to glide through that upper trapezius. Now there's a lot of different sections you're going to want to hit into that upper trapezius, and so feel around for the myofascial dysfunction. Spend a little bit more time, maybe some trigger point release with the blade of your forearm getting into that. But what really helps here is the fact that you're elongating while you're applying that myofascial release. From there, I'm going to go ahead into the levator scapulae. I'm going to find the proximal attachment of the levator scap at the superior angle of the scapula, and I'm going to pin that down, and then ask the patient to let me bring their head down into flexion with contralateral rotation. Once the patient gets used to this movement, this is one of my absolute favorites to start implementing some active motion. So I'll go ahead and pin my thumb down and then ask Justin to tuck his chin and then bring it down and rotate away when you get to the bottom. And the reason I like to use this is because I actually find the levator scap to be a pretty significant culprit in the scapular elevation in those patients who wear their shoulders for earrings or the major upper cross cases. From there, we can talk about the anterior musculature. And as we look at the anterior musculature, you want to be cautious to make sure that the patient doesn't have any major vascular or autonomic responses. I've actually had colleagues tell me that they had patients pass out when they were getting soft tissue work done in the anterior neck because you've got to consider all of the vascular and autonomic structures in there. So make sure the patient is aware when you're working with them to let you know if they start to feel dizzy or woozy or a little bit uncomfortable so that you can back off a little bit. The first one I'm going to show is going to be the scalenes. And so I'm going to track down the sternocleidomastoid, get just behind it into those rocks. And pretty much everybody's going to have those rocks back there because these are muscles that don't respond well to the posture we keep these days. And then you get right on top of that scalene. Now, when you're into the scalenes, it doesn't take a lot of pressure. They're very sensitive muscles. They're not very powerful muscles. They're designed predominantly for proprioception. So we're just going to get a gentle contact on those scalenes and then rotate the patient's head away. Gentle contact, rotate the patient's head away. If they need a little bit more, you can take them through a little bit of extension or apply a little bit more pressure. But be cautious, this is usually one where the patient needs you to back off, especially if they're getting referred pain up into the head or around the eye or something like that. Then from there, we'll go into the sternocleidomastoid. When I'm working with the sternocleidomastoid, I have two different techniques. Now, if I have a patient who has suffered whiplash trauma or some other injury that's overstretched the scalene or the sternocleidomastoid, I don't want to lengthen that more. And so in that case, I'm going to go ahead and take my fingers like a hook, get inside the sternocleidomastoid, and kind of scoop and drag up inside as I approximate the tissue by bringing the head down and forward. So I'm going to hook in there and scoop right on through. If I'm dealing with a patient who's got an extremely tight and overactive sternocleidomastoid, which is pretty common in those patients with upper cross syndrome, then in that case I'm going to use a pin and stretch technique where I'll find that sternocleidomastoid, and remember we have the two proximal attachments that you want to work through. Pin it down and then go ahead and bring them into contralateral rotation with extension, trying to elongate that sternocleidomastoid as you take it through the range of motion. The other one I want to work on here is the pectoralis. And the pectoralis tends to be a tricky muscle. A lot of people will compensate when you're trying to work on it. But we want to make sure that we get good scapular protection and scapular stability. And then we also want to try and make sure the patient is as relaxed on the arm as possible. And so we're going to bring their arm out into an abducted and externally rotated position. I'm going to put my hip against the scapula to help stabilize it. I'm going to use my hand from the opposite side to hold the arm up, while I take my hand on the same side and pinch his elbow against my torso with the forearm. And then from there, I'm going to take my finger as a flat blade underneath the pectoralis and then pinch over top of it with a flat blade on my thumb. If you dig and pinch with your fingers, it's going to feel like you're stabbing them with a needle. We don't want to do that. We want to stay nice and flat, take our contact, and then glide on through as we pull them into this horizontal abduction. So we're pulling the arm back toward your body as you pinch and glide through that pectoralis in order to work on elongating. Now you'll see it's not a dramatic range of motion. It's just enough to put tension and iron out some of the myofascial dysfunction inside that muscle fiber.